Wonderful. Good evening, everyone. My name is Dr. Linda Bello, and I'm the chairperson of CamDocUK. I would like to warmly welcome you to the 22nd edition of our Talking with the Community webinar series. We are thrilled to have such an engaged audience for today's topic, which is going to be navigating dementia, early recognition, diagnosis, and support systems in the UK and Cameroon. Dementia is a growing health concern that affects millions worldwide, and its impact is felt not only by those diagnosed, but also by their families and caregivers. Through this webinar, we aim to shed light on the nuances of brain aging, recognize early signs of dementia, and address the unique challenges faced in caregiving, especially in Cameroon. We'll also discuss approaches to diagnosis and management, highlighting the importance to support systems in both the UK and Cameroon contexts. We are so very fortunate to have an incredible lineup of speakers today. Dr. Ngwa will start by discussing normal brain aging and dementia. This will be followed by Dr. Chi-Mbatoh, who will be guiding us on recognizing early signs of dementia in the community. Next would be Mrs. Ngang, who will address the challenges of caring for someone with dementia in Cameroon. And finally, Dr. Ebode-Ntsama will speak on diagnosis and management of dementia in Cameroon. Each speaker brings invaluable expertise and perspectives to the table. So some general housekeeping before we start. Please do put all your questions in the Q&A box as we go along. So without further ado, it's my pleasure to welcome our first speaker, who is Dr. Valentine Ngwa. And we all know Dr. Valentine Ngwa, but I'll tell you a bit more about him. You may not know. So he finished medical school from the University of Benin in Nigeria. And after working in Cameroon for 3.5 years, he moved to the UK in 2003, where he did basic specialist training in Leigh teaching hospitals, gaining an MRCP UK and diploma in geriatric medicine from the Royal College of Physicians of London. He's then spent 2 years doing a higher specialist training in cancer medicine before moving to spend 5 more years doing a dual accredited high specialist training in geriatric medicine, which is elderly medicine, and general internal medicine, gaining yet another qualification, MRCP UK Geriatrics, and he completed his CCT. He also holds a postgraduate certificate in medical law from Edinburgh University, a postgraduate diploma in therapeutics from the University of Cardiff, an MSc in social gerontology from the University of Southampton, and an MSc in aging from the University of South Wales. He works as a consultant geriatrician and acute medicine physician in Mid-Yorkshire Hospitals NHS Trust. He is also our previous educational lead for CamDocUK. And from the bio I've just read out, you can see why he was our educational lead and the perfect person to give us this talk today. Dr. Ngwa, over to you.
Thank you so much, Dr. Bello, for that lovely introduction. I'm honored to be here. I'm going to share my screen if I may. Hope it works. Now, can you see my screen at all?
Yes.
No?
Yes.
Sorry. Can you see my screen by any chance?
Yes.
We can.
Yes, we can see your screen.
Okay,
Yes,
sorry.
we can.
My computer is playing up. I've got two computers in front of me, so I just get this one up. Right, thank you once more. I'll be talking about normal brain aging and dementia, which is, as you can imagine, is quite a broad topic. So I will try and fit it in the 15 minutes that I've got. Just as an outline, I will give a short brief on what happens with the brain as we age. Talk about some of the neurocognitive problems, so the problems that could occur with our cognition as we age, including mild cognitive disorder and dementia. And I'll also talk about some of the principles on which we manage these conditions. Now, we could define aging in a couple of ways, in a few ways. The most common one is to define aging as in a chronological fashion, which you would think that from the day you were born, you are getting old, so you are aging. But I want to define aging as the distinguishing it between growth and aging. So when you were born, you were growing up until the age of 25, 30, then you start aging. So from 30 onwards, you're aging on the average. And what that means is by the age of, say, 40, you start losing brain cells. That process accelerates at about 70 years as well. Now, when you're losing brain cells, you're not losing brain cells the same way in all parts of the brain, because not all parts of the brain has the same demand for nutrients and oxygen. There are some parts of the brain that have more demand than other parts. As you can imagine, you use your memory more, your thinking, your ability to know where you are if you're walking the more. So all those parts have more demand. And those are the parts where you tend to lose more neurons, because the basic thing is that the blood vessels to the parts of the brain gets narrowed down. So those parts that need more are the ones that suffer the most insult as you go older. And what are those parts? They're the parts in which, for example, you use for memory. And that's more reason why when you start hitting the age of 50, your memory is not as smart as you were when you were in your 20s. In fact, by the age of 55, you start having what we call the tip of the tongue phenomenon, where you would know somebody's name, but you really can't get it. These are all parts of aging that are normal. And also those chemicals that allow the cells of your brain to communicate with each other are also reduced. They're called the neurotransmitters. And so progressively, the brain ages. If you look at the diagram there, the one on the right is that of an 82-year-old man. You can see there are more black spaces than the one on the left. Now, those white and gray spaces are actually the brain. So you can see it's shrunk a bit. And that's what you will get with normal aging. And what does that mean? That means that our short-term memory declines as you go older. The way how you can remember something in the next 15, 20 minutes when you were told is not the same as when you were younger. Your ability to keep an attention on something gets diminished as well. So if you're telling something to your grandma, a long story, be very sure that she might not get it as much as you are getting it. And also it's very slow how we process information. And that's why you see older people don't drive very fast on the road and stuff like that. They need time to be able to get things into perspective. They have a poor ability to do more than one thing at the same time. I mean, just imagine our young ladies can cook a complicated meal as Ndole and still be on the phone talking to their friend all the time. Because cooking those meals, you have to put the ingredients at a particular time, otherwise you jumble them up. But they can do that and still be on the phone. But if you allow your grandma to be taking her medications and keep her on the phone, she's going to take one medication more than the other because they cannot multitask. But as you get older, one thing that actually increases is our vocabulary, because we learn new words as you go older. What shouldn't change actually as you get older with the brain aging is our immediate recall. So if I give you six numbers, you can repeat them back to me immediately, which means that you can recall them. As I said before, your vocab increases, so your verbal intellect shouldn't go down. Your long-term memory stays intact. In fact, grandparents are always fond of telling old stories because they can remember those old stories very well. And your intelligence shouldn't change. I will just try and break that down a bit. Now, intelligence could be seen as a combination of fluid and crystalline intelligence. So fluid intelligence is the ability for you to make decisions when you're given a new task. So if you are appear in a new city, how you can navigate yourself or make quick decisions, that actually goes down. But your crystalline intelligence, which is considered as wisdom, actually goes up. So when you put both of them combined, it shouldn't change as time goes on. Your ability to learn new information should also be there. It might be slower. Those who go to adult school might find it difficult to get information than if they were younger, but give them time and they will get it. When this starts changing, your thinking, your memory beyond expected for your age, your language, you start finding difficulties in stringing sentences, find difficulty finding words. I wouldn't dwell on this because the next Dr. Chi-Mbatoh would take this a bit more in details. But when this starts changing and is persistent, and you start finding that it's getting worse, then it's time to think about it. Because you might be getting into the abnormal range, and the abnormal range can actually overlap with the normal range. I must say here that it takes a few years to go from normal to the mild cognitive impairment and to the dementia range, which we will talk about. It doesn't just progress in a few weeks or in a few months. So if that somebody should change like that, then maybe it is something else. However, you could still move from normal to dementia if you've had a catastrophic brain injury. Say you had a big stroke, a very rapidly spreading cancer, you've had trauma to your brain, or you've had an infection in your brain. Those are the kind of conditions which could make you move from normal to dementia. Otherwise, you tend to progress very gradually and slowly. And so what is my cognitive impairment? Is that time where you have, well, my forgetfulness more than for your age, you struggle with what they call the instrumental activity of daily living. So the complex thing that you do, like managing your finances, going to the bank, driving in an unfamiliar environment, you start struggling with those. But the things that you do to survive at home, you're still intact, like washing and dressing yourself, cooking and cleaning, you can still do all those ones. So when you go get those tests done, they could actually say, well, you are getting the mild cognitive impairment, which means therefore that given time, you could get to the point of a dementia. Again, it depends on what is causing this, as we will see in subsequent slides. But that said, if at the point in time where you now start being unable to take care of yourself, so live independently, you start needing help because you have a disorder in your thinking and your cognition. So, and by cognition, I mean your memory, your perception, your reasoning, your language and judgment. You start getting problems with those, and you cannot live independently, so you can't wash and dress yourself and cook and clean. Then we now say you possibly are developing a dementia. And the word dementia, I said, is an umbrella term. It's not a diagnosis. So there are about 70 to 100 things that can cause the dementia. And the problem is you might be entering the dementia spectrum of what particular is causing the dementia. In this talk, we can't focus on all those causes, on those other reasons why you could develop dementia. I'll try and pick a few, which are the most common ones, and I'll talk about them. Most times when people talk about dementia, they equate it to Alzheimer's dementia. Now, I will start by talking about Alzheimer's, which is the most common one. Alzheimer's disease is different from Alzheimer's dementia. What Alzheimer's disease means is a condition whereby you're not having abnormal plaques deposited in your brain. You're having abnormal plaques deposited in your brain, in particular parts of your brain, and as time goes on, this causes an inflammation and causes you to lose cells. By the time you start developing symptoms, which we could say you got dementia, it could have been 10 to 20 years when you start developing it. So getting Alzheimer's disease doesn't mean that you have Alzheimer's dementia, but give it time, you develop Alzheimer's dementia. And there are four major spectrum. Many people think dementia is memory. So when you say my memory is going, people think dementia. Well, it doesn't necessarily mean memory. It would get to memory subsequently, no doubt, but it could start without memory. My colleague, Dr. Chi-Mbatoh, will try and speak about some of those things as we picked them on the earlier, but I'll just say the four classical ways in which it might present. The classical one, which we know, is the memory syndrome, which is the most common one many people think about. And what happens here? Unfortunately, I couldn't show you the part of the brain involved here on the scan. This is the scan of a patient. You can imagine the brain has been sliced and you're looking from the foot upwards. So the A part is the frontal part and the C part is the back of the head. There's a part of the brain they call the hippocampus. Hippocampus is Greek word for seahorse, which is very instrumental in our memory. What it does is it translates memory for us to store it. So I want to, if you consider the brain as a storehouse for information, like a library, then I want you to consider the hippocampus like a librarian. The librarian will take information and store in the library. Now, when this hippocampus is affected, the librarian cannot store information. So you might tell the patient something, they might repeat it to you, but give them 5–10 minutes, they will not remember again because they have not stored it just yet in their brain. And this is what happens with this variant of Alzheimer's disease. The second is the language, and it affects the part which I've marked as B on our scan. Now, language is a complex phenomenon. How we know the words that we know is because we have been able to memorize them and store them in part of the brain. And so if you say, what is a table? You know it's a four-legged thing with a flat surface, and you know table. But when that part of that brain is eroded, you might recognize it, but you might not be able to bring that word, table. And sometimes you might not even be able to understand what somebody is saying, or you might understand it, but not be able to actually say it out. So the language is the first thing that goes. If you remember, Bruce Willis started getting a concern because he was having word-finding difficulties. These are not names of people that you've known 20 years ago. These are common things. So, for example, somebody wants to call a bucket. I mean, these are things that you should know, or a chair, and they start struggling with those things. Then there's probably the language variant. Now, the third one is the visual variant, which occurs in the part of back of the brain where I've marked as C. When you see something, what happens is rays leave what you're seeing, come to your eyes perceive them, but your eyes take those information to the back of your brain to interpret them. And that's how you know what you're seeing. When this part is now damaged, what happens is you find difficulties interpreting things. So you can't read words in a line. You can't process. So if you go to a fridge to take out a jar of milk, you will not be able to know what it is. If I give you a picture with many things there, you can't make sense of it, or because you're unable to interpret what is happening there. So when you see people start having that, then possibly they're having the posterior variant of Alzheimer's disease. And the last part I'll talk about is the frontal variant. Now, this is very important because the frontal lobe, this is what affects the part called A. And this is actually why I put this diagram, because if you look at this diagram, at the top mark A, you can see more black spots there, which means that the person is losing cells on that frontal part. Your frontal lobe is a very important part to how you execute executive functions. In fact, I'll call it the CEO of your brain. That's what teaches you how to maintain yourself, how to have impulse control, how to have empathy, how to be inhibited. You don't just see something, you don't just walk on the street, you see somebody with a big head and say, oh, you have a big head. You're able to control yourself, you're able to, how you spend money, how you gamble, how you don't just look at fine women and you start touching them and stuff like that. And you have those control. That's what the frontal lobe does to you. But once it is going, then there is a problem. And some people start manifesting by those symptoms. I think Dr. Chi-Mbatoh will talk about that a bit more as well. But the frontal lobe variant is very important because some patients don't actually have a memory problem, but that's what they have. So you will see somebody who has been upright all through their life, a school teacher, very decent, respectful, bringing up kids. They got up one day, sexually molest a child. And people will wonder, hang on, what's happening here? Just because the frontal lobe is going. I'll also emphasize on this because the frontal lobe actually doesn't develop fully until about 25–30. And the frontal lobe is very susceptible to damage by excess alcohol and drugs. This is one reason why we have to tell our younger people, if we want a decent society, to stay away from excess alcohol and drugs, otherwise they damage the frontal lobe. And that's the more reason why you see people who've been drinking heavily from teenage years, they never grow up. They never take responsibility. They're always like teenagers because the frontal lobe has actually not been allowed to develop fully. There are other dementias. I wouldn't be able to get into all of them, but I'll make mention. Now, Alzheimer's dementia is a problem of the brain. The next one, vascular dementia, well, it could affect the blood vessels as well. But vascular dementia is primarily a problem of the blood vessels. So vascular means blood vessels, the arteries and the veins. And the basic problem is that the blood vessels start getting narrowed, and so blood supply to part of the brain starts diminishing. The hallmark of this is patients have a lot of emotional liability. So some people just laughing unnecessarily or crying when it's not necessary. You know, I mean, if you go to a happy occasion, sometimes you cry out of joy, but you could just ask somebody, how are you? And you start crying. Suffice for me to say, from diagnosis to death in Alzheimer's disease could be about 8 to 12 years. But in vascular dementia, it could last a long time, it could last a very short time. It depends on how bad it is, and they could stay constant and then suddenly deteriorate. Now, Lewy body is another one I just want to mention, is because sometimes people could confuse you with Parkinson's. They're actually the same spectrum. The type of thing that causes Parkinson's causes Lewy body, does that from different sides of the brain. The hallmark here is patients have a visual hallucination first, so they start seeing things which are not there for the confusion. And then if you give them time, they start getting stiff and start shaking like Parkinson's disease. There's a difference between, because Parkinson's can also cause a dementia at the later stages, but Lewy body is different because the hallucinations and start before the person starts shaking. And most times, patients don't have one type really, they have a mix of them, mostly the mix of the vascular and the Alzheimer's dementia. Just quickly mention that alcohol is a very strong reason for people to have dementia as well, for quite a few reasons. One, alcohol is bad for the brain cells, damages brain cells. Two, people who drink heavy alcohol are always deficient of the B vitamins, particularly B1, which is very important for brain cells nourishment and development as well. So they develop what they call the Korsakoff syndrome, which is an alcohol-related dementia. And the last thing I would like to mention is HIV and syphilis are quite important in dementia as well. In our society where it is a bit high in prevalence, we're going to find quite a few people coming down with dementing processes due to HIV. And that's the more reason why a young person with cognitive impairment need to have screening for those. How would they present to us? I'm going to talk about the hospital setting. My colleague, Dr. Chi-Mbatoh, will talk about the primary care setting, how they present to them. They will present to us, one, because somebody has a sudden deterioration. The family comes to you and say, oh, my dad just got very confused suddenly and stuff like that. If you go back and you unpick it, you'll find out they'll be having memory issues going back a few months. But there must have been a trigger point. And the trigger point could just be anything. It could be an infection. It could be a new medication. It could be a change in social circumstances. It could be trauma. They could get any other disease like anybody else. We also come into hospital because somebody who is non-dementia has deteriorated. Now, one thing we try to do is to make sure that it is not other things that can mimic a dementia, like delirium, which unfortunately we will not have time to talk about delirium today, but it's an acute brain condition, or even a depression. Don't forget, people with dementia get frustrated and they get quite anxious and depressed as well. So all those could actually make them to go downhill. It could just be that they got difficulty managing the community. We're talking more about mild syndrome at the moment, but when they start getting worse, they start having different complications, swallowing problems, other problems like just walking, and some of them get quite aggressive because they don't feel understood. So they can't appear in hospital because of that. And what we do when they come is we try and do some basic cognitive screening. I want to emphasize here that all those tests that you take your mom and your dad and they go to hospital and they do the screening, either as MMSCE or a MOCA or a mini-COG, they are not diagnosis tests. They are just screening tests to say whether somebody could potentially have dementia or not. And this is a caveat. If you take a clever person who's got dementia and you give them those tests, they'll pass it. But you take somebody who is not so clever, who hasn't got dementia, and give them that test, they might fail it. So the test doesn't really diagnose dementia per se, but it is a pointer. And when that happens, the medical people want to rule some reversible causes that could cause this: thyroid disease, vitamin deficiency, brain tumors, so get brain scans, infections, and stuff. And there are a lot of supportive measures. Again, as I said, we can't go through all that in this webinar. But don't forget that there is a service called the memory service, which these patients will have thorough neuropsychiatric evaluation there. I borrowed this slide from the last British Geriatrics Society conference. And what I'm trying to emphasize on this slide, and I'm sure those who heard me speak many times, I always try to always say this difference between medical care and health care. These are the risk factors for dementia, and as you can see, 60% of the risk factors we don't know. And that's why dementia research is very important, it's going on. But 40% are potentially modifiable. And while we know quite a few some, so if from childhood, if you didn't go to school, well, you already have a 70% chance, 7% chance that you miss the possibility of having a reduction in your risk of dementia, of having a dementia. Hearing loss is very important. In fact, all the senses really, vision and hearing, it's very important that they get addressed. And while we will not be surprised by things like hypertension and alcohol use, let's say smoking has 5 times the risk reduction to diabetes. But I'm more concerned with the social isolation, which we tend to see in our elderly patients. To bring our moms in the West, we keep them at home, and then we go to work every day, they're at home by themselves. It's quite damaging to them. And as somebody from Bamenda, I really can't stop without saying this: air pollution. At a point in time, Bamenda was considered the 8th most polluted city in the world. But I'm sure if you go to Bamenda and people, don't get me wrong, diabetes is a very important cause of dementia, but air pollution has twice the risk to dementia. So I'm sure people will be more interested in managing patients' diabetes than looking at the fact that air pollution control could be something we should really make our effort to reduce. And how do we slow progression or even prevent them coming? There's nothing more than brain activity, getting education, learn new skills. Nothing more than alcohol reduction. Alcohol is bad for the brain. And the more we can cut down alcohol, the more we can sleep and exercise. I will never emphasize that enough. Adequate sleep. When you sleep, particularly when you go into the 3rd phase of sleep, your brain, that's the time your brain cleanses itself. And so if you're having interrupted sleep, you're actually causing more harm to your brain. That's why people with sleep apnea are given a CPAP machine so they can oxygenate their brain, because it's very damaging as well. Gut health, nutrition, these are various things we can talk about. Unfortunately, due to time, we can't talk about them. But let me just emphasize stress reduction. In the West, we're facing a lot of stress, persistent stress every day. It is as damaging to our brain as anything else. So keeping yourself in a community where you can manage your stress perfectly well is one of the things we should be doing for our brain health. There are various different principles of managing patients with dementia. And I emphasize that it is not, they need care, but it's not caregiving, it's care partnering. Because the carers of dementia patients have to understand how patients how their brains operate to be able to manage them. Otherwise, they get quite frustrated, because if you see, for example, one of the dementia patients who soiled himself and you want to clean them, according to you, the right thing to do. You soil yourself, I need to clean you. But that's not how the patient sees it. So they perceive it differently. There's now anxiety, there could be aggression, and then there's now a breakdown in that caring process. So care partnershiping is very good. Helping with everyday tasks. That's why physiotherapists are important, occupational therapists are important. There are specially trained nurses that are looking into this. I'm sure we could talk about it. Emotional support. They need empathy, particularly those who have emotional lability. Now, there is the thing now in many parts of the world where they're developing dementia-friendly homes and environments. Because sometimes those environments has been shown, and because it emphasizes what they call reminiscence therapy, has been shown to be more effective even than medications as well. And of course, these patients are going to have other medical conditions. They're going to have pneumonias and heart attacks and stuff. We have to manage that. Just a word or two about medications. There are medications for Alzheimer's dementia. It slows that down. The evidence is that it could buy you 2 or 3 years the maximum. So there are some that we'll give to our patients who've been known to have dementia. We know that some of them withdraw from the market, the new ones have been withdrawn. There's a lot of studies into developing new ones. Just to talk about creating environment for patients with dementia, These are 4 pictures. The one on the right is the dementia ward, where you just the fact that there's a bus stop sign there, these patients would know that they used to come to the bus stop and sit down and wait. So they'll just come there and sit down and wait. Give them a paper and they'll be there the whole day. Because when they were younger, that's what they do. They go to the bus stop and they wait. Now there is a village, the one on the bottom left, there's a village in Holland, which is actually a whole dementia village. You just get those people go there. They have all those things, the cinemas, the post office, so they can roam around and do their things, and people are not restricting them, because sometimes trying to restrict them from doing what they want to do actually is the problem. So the principles is we need to recognize dementia quite early, as my colleague will talk about in the next speaker. The reason why we want those early recognition is because we can get help earlier and get more information. Loads and loads of information out there, loads and loads of dementia societies out there. Dementia UK is there. We need to maintain meaningful interaction with patients with dementia and understanding, which means carers need to get training to understand how those people perceive things, how people with dementia perceive things. Because if we think they're going to think like us, then we have a problem, not them. Sometimes we used to always say, the patients, they're difficult to manage, and then we now say, oh no, they got high needs. Well, we have high needs than them because they are operating at the level in which their brain can understand it. Just like dealing with a child. Dementia is a process that actually reverses life. So we're born, we can't control our head, we start controlling our head, then we started crawling, started walking, started talking gibberish, started talking anything we see, started thinking, started making sense, started to frontal lobe, now start having complex thoughts. Dementia starts reversing all that. And at some point in time, you're going to have an 85-year-old lady who says to you, oh, I want to go home because my mom is waiting for me. The mom died like 50 years ago because she sees herself like a 20-something-year-old. She will see her daughter who is say 50 and refuse that it's not a daughter because she can't see that she has a daughter that old. She's not reversing life, and that's what happens. And when they get distressed, we need to recognize those signs and see how we can help. So in conclusion, then, and I'm sorry I'm taking a bit more time, not all dementia is Alzheimer's, but you could have Alzheimer's disease without having dementia as well, and vice versa. Lifestyle is very important. Social connections, how we live, stress reductions are also as important as as medical problems. But ultimately, once we've done all the reversible causes, dementia is terminal. So it's going to get serious to the mild, moderate, and severe state, and find the terminal state needing palliative care. And when we're developing care for these patients, we should always remember we're partners in care, we're not caregivers. I'll stop there and take some questions. Thank you.
Wow, thank you so much, Dr. Ngwa. And yes, you did run, you spoke longer than expected, but it really was a masterclass. It's your field, you know so much about it. I know we could do 3 webinars and it won't be enough. There's so much more you wanted to tell us, but it was amazing. Thank you so much. As you can see in the question and answer box, there's many, many questions on there for you. We'll probably take 1 or 2 and then we'll move to the next speaker. So there's a question from JC Kate. I think you've answered his first question, which was, is there anything one can do to improve or guard against the age-related brain aging you mentioned at the start? And I think you had a whole slide on it about what to do, brain activity, sleep and things like that. There was something on there called the Breseden Protocol. What was that, Dr. Ngwa?
Yes, Breseden Protocol is Breseden Protocol is a combination of things that you could do, including gut health, nutrition, reducing inflammation, reducing stress. This Breseden is somebody who has come up with this. He does a lot of functional medicine, which of course has a place in medicine at the moment, which shows that we're just dealing with the symptoms of the diseases. We need to go to the origin of it all. As we know, dementia has got different theories why it arises, and one of them is the theory is that our gut is responsible for a lot of the things that goes bad in our brain.
Yes.
So put down all this whole package as a protocol where people can use to reverse the dementia. Now, the research evidence is not very strong, but these things are the things that we'll talk about to prevent people getting worse dementia anyway. So we imbibe that down to say, if you're giving advice, those are things that people should actually be doing. Their nutrition, their gut health, their stress reduction, exercise and all those things, yes.
Excellent. And his second question was that, can overlearning, so academicians, for example, help or enhance brain aging, leading to dementia as an independent factor?
Well, the more you learn, the more your brain cells have more connections. So it's actually protective.
Yes.
The more you learn new things, the more you learn, it's actually more protective, because if one part of the brain gets damaged, you could have the other part dealing with those functions for that part that has been damaged. So yeah, it's actually protective. We actually had a professor one time who had a severe brain injury from an out of hospital cardiac arrest. He was fantastic in all those tests, but he had severe brain damage from that incident. If that wasn't somebody who was that knowledgeable, who would spend those times studying, I'm sure the manifestation would have been more severe. So yes, learning new things, academics, they have lesser chance of getting dementia.
Amazing. So one other question, then we'll go to Dr. Chi-Mbatoh. So this is from BKMI. Is aging, underlying studies and finding true of contemporary trends? Do aging and time enjoy a correlative or a causative relationship? You might have to answer some of this in the Q&A, it's very long. How much of this is a natural social conditioning and self-hypnosis as we prepare for retirement, which is in principle preparing to die, a process which engenders fear, distorts biochemical homeostatic balance, habits leading to excessive stress, and by inference, rapid deterioration? Basically, how much of it is nature versus nurture?
All right, very good one there. I try to, I'm sure everybody who's heard me speak, I always try to differentiate aging from the chronological age to biological age. And a lot of the retirements are based on the chronological age, not the biological age. And we know that there are some things that you could do that will actually make, though you might be chronologically 70, but biologically 50. And so if people can actually, if you keep everybody living, they're going to get dementia at some point. But it's how far, how quick they get to that varies. Some will get it at 70, some will get it at 90, some will get it at 120, some will get it at 140, because age is the most important risk factor. And that age is not chronological age, it's biological age. So as long as we can do the things that make our biological age to tick slowly, then the more we can prolong how soon we get those dementia. I'm sure there's a lot we can talk about this, because there's a lot of studies now on what they call neuroplasticity. We thought before that if you lose brain cells, you can't get them back, but we're now beginning to see that you could really get them back, and there's a lot of work on that. I'm sure this is a topic we can talk about it extensively as well.
Exactly. Thank you so much, Dr. Ngwa. And if you can see on the chat, many people really resonating. They really loved your presentation. Fantastic presentation, very informative and things. You might have to go to the Q&A, but I think the best one was from Stella, who says it was very educative and even she can understand it. So well done and thank you. So moving forward to our second speaker. It's another CamDoc member. We're not being biased. It's just that we have a lot of people in CamDoc that know about this topic. Dr. Paschal Chi-Mbatoh is a lead GP at Leigh Sports Village Surgery, and he's the member of the Royal College of General Practice. As I said, he's a CamDoc member, one of the nicest people you'd ever meet. Very, very into education as well. So over to you, Paschal.
Oh, good evening, everyone, and welcome to this webinar. Can you hear me?
Yes, we can.
Hear you.
Excellent. Right, so I'll try to share my screen before we go. Okay. Right. I think, are we on now? Can we see the screen?
Yes, we can.
All right, that's good. And thank you very much, Dr. Ngwa, for, I'm sure everyone that has listened to this would say yes, you've done a good job to make things easy for us. I'm not sure anyone will be able to beat that, but thank you. The task that I have this evening is to discuss the early features of dementia in things that we can see in the community to make us suspect that someone has dementia. I'll try to be as quick as possible, but as you know, this is quite a broad topic. There are a few key facts here. Worldwide, there are about 50 million people with dementia worldwide. And every year, 10 million people are diagnosed with dementia. So this is quite a very important topic. And as there is advances in healthcare and people are living longer, you find that we'll have more people with dementia. As Dr. Ngwa has actually said, the main risk factor is getting old. And that is actually confirmed by the fact that 41% of people above the age of 95 years of age do have dementia. So it is something that we need to actually take seriously. Now, when we talk about dementia, we need to first of all know exactly what stage of the disease we are talking about in these individual persons. You have the early stage of the disease. Usually it is very mild, usually lasts between 1 to 2 years, and many family members or friends may overlook this. And because of that, it is difficult to diagnose at that age. But as we go through this discussion, we should be able to pick up some few clues that will help us identify individuals that need screening for this disease in the community. Now, for those patients that have the middle stage of the disease, that is the moderate dementia, this period usually lasts between 2 to 5 years. And what we find is that some of them will find it difficult to prepare their food, and they may need help with their personal care. And you see that it's quite different from the early stage of the disease, where most of the time these patients are independent and they do their things by themselves. But as we get older and you're 5 years or more into the disease, you now find that the person may become less active and more dependent on family members and friends in doing things. So those are cues that we have to look into when we are thinking of our relatives and we are thinking of getting them assessed. So let's look into more detail. Dr. Ngwa has actually talked about this issue of memory loss, short-term memory loss. You see that the person may forget what they ate for breakfast, and then they may also start forgetting important times and important dates, like birthdays of their kids or their own birthday. Then they may be forgetting times of meetings. And if you look closely or you are living with them in the house, you may find that at particular times they may be asking several questions repeatedly. They will be asking the questions. Even when you answer the questions, they still go on asking the question. Then at that point, it should trigger the plan to either see your doctor in the community or take the patient to someone who can actually assess to see what is going on. You also find that these persons find it difficult to develop a plan. And what do we talk about a plan? They will struggle to do things like performing simple tasks that initially they were able to perform. They belong to a dance group, and then when they go out to dance, you see that they are dancing. Initially, they were dancing in a synchronized manner, but now they are not dancing in that way again. Then it may take them a longer time to do the same things that they used to do within a very short period. And when you look at it again, more detailedly, if you're living with them in the house, you now find that they will struggle with their shopping. even to make the list for things that they have to go and buy in the market. Or when they go shopping, they will struggle to make a decision on what they want to buy. So these are simple things that you can easily recognize amongst your family members. And when you see this, it is important that you get them assessed by a qualified clinician. Then they may start also having problems with timing and place. They will lose track of the time of the day and seasons. So you wake up in the morning in Cameroon on a December morning and you ask, oh, what season are we in? And they will tell you, oh, we are in the rainy season. And then in England, they will probably tell you that they are in summer when we're actually in winter. Then when they travel somewhere, they will struggle to actually tell you how they got there or even where they are. They may not be able to identify where they are. So they get confused. And sometimes you may find that when they go out to places or they leave the house, they go to church, they may just be wondering they may end up not getting to the church. Or even when they leave the church and they're going back home, they get lost and they may need assistance for someone to get them back to where they are coming from. So these are things that should trigger a visit to the doctor to make sure that they are investigated to know what is actually causing the symptoms. Because as Dr. Ngwa has rightly said, this may not actually be dementia, but it could be a trigger of something going on which needs investigating. Now, some of these persons may also have problems with their speech. They will have problems with finding the right words or even writing and spelling. Now, when you're having a chat with them, you see that they may stop mid-sentence and then change the topic. And this usually happens because the amount of vocabulary that they used to have has reduced, and then they will struggle to communicate. And some of them now respond to this by now becoming withdrawn. They would stay away from crowds. They would not want to find themselves in situations where they have to be challenged, because that actually puts them under a lot of stress. And if you're living with a family member, you may also notice a few things. A family member who is developing dementia, you may also notice a few things. They may now decide to put ice cream in the oven, or the fry pan, they'll put it in the fridge. And then you'll find that in the same fridge, you'll find socks. So these are trigger things that should make a family member say, oh, there is something going on. This is not my mom, this is not my brother, or this is not my sister. Let's go and get this person assessed. And then normally in aging, somebody will hide keys, and then when you ask where is the key, they will go and get it for you. But in dementia, you find that the person will not be able to trace where they kept the key. And that can actually be very frustrating. They may hide cash, and then they will not be able to identify where they hid the cash. And sometimes they're less careful with the money. They overspend the money. And in this situation, you find that they become very vulnerable to some family members that may just be using their cash or taking their things without control. And as said before, you will find that these same patients or these same persons will be very anxious, they'll be nervous, especially when they find themselves in environments that they are not familiar with. You admit them into the hospital and it just increases their level of stress and anxiety. They become very suspicious of people around them, and it makes them very withdrawn and they don't want to even talk. So the key issue there is now to understand what is going to happen by taking them to the doctor, let the doctor assess them, and then make a diagnosis, because after that diagnosis, they will be able to make a plan for the care of the person. We may also recognize that some of these patients or the person may become very bold and they start doing things that normally they wouldn't do, or things that the society identifies as out of the social norms. And as Dr. Ngwa was explaining what happens to the frontal lobe, you now find that they may be taking their clothes off in public, and then they may be rude to people, and this will be out of character. And then, yes, some people may flirt, but you will find that these people would flirt in a little bit an unusual way that their own flirting will be, and those type of things should trigger a visit to the doctor. So the question we ask in this situation is, does this patient have dementia or with something else? And to address those questions or to get the answer, we visit the doctor, as Dr. Ngwa mentioned. But in primary care, when you come in, we will be thinking, is this a urinary tract infection? Does this person have HIV? Is it syphilis? Is this person taking a lot of alcohol? Is it medication? So we look into all that. Is this all stress related? Or are there other metabolic problems like vitamin deficiencies, changes in the blood sugars, and or this person has a brain tumor or has had a stroke? So we have to look at the overall picture before we go ahead and make a diagnosis. So when the family member or friend or relative decides to now say, okay, now I want to go and see a doctor, we come into primary care, what the doctor or the assessor will first of all do is to get a memory assessment after doing the standard things that we do by taking a history, a detailed history. When we do the memory assessment, we will also request some blood tests, urine tests. We may also do an ECG, and some or most of the patients will require some tests like a chest X-ray and a CT scan, because all this is to exclude other causes, those things that are reversible or things that will need a different form of treatment. Once that is done and the clinician or the GP like myself is happy about it and we think, oh, this could be dementia, then we would refer the person to the memory clinic. Usually, the memory clinic would now see the person, assess again, do some tests, and then come up with a diagnosis. Once that patient, this is actually what happens in England, once that patient is diagnosed, the patient, if the patient meets the criteria, they may start the patient on medications. But again, most of these patients don't need medications. What they need is all the things that Dr. Ngwa discussed in his care plan, where the care partnership with the patient. So the doctor, the primary care doctor like myself, would have to review the patient, make a care plan depending on each individual patient's circumstances. So the medical treatment, again, only slows down the disease. As Dr. Ngwa said, only gives about 2 to 3 years. But the main issue here is the non-medication treatment, which is the support. And there are quite a lot of links that patients can have and family members can have, so that these links would give them information that can support them. Like we do have the Alzheimer Society, even NHS England has information leaflets that do give information that can help carers to take care of this patient. But one thing I would say is you can have 5, 10 patients with dementia, and they will be different. That is why I've got this form here, which we call that we call it the "this is me" form. What does this is me form mean? It tells you about you, what your likes are, what your dislikes are, what you would like when you want to eat, those things that actually help the healthcare professional or your family member take care of you. So in doing the care plan, for each patient, we individualize their care. And this actually helps the patients have a better quality of life because the people around them would now be able to understand how to take care of the person. And there's quite a lot of things that we can talk about this, but I would say if we don't have any information from here, what we should know is that each patient who has been diagnosed with dementia would need to be individualized, and we will need that "this is me" form, that when you go anywhere, you can show it to someone that this is my mom, this is my dad, this is my brother, and they'll be able to offer the care. And with that, I would say I would end my presentation, and I'll be able to answer any questions that you provide. Thank you very much.
Thank you so much, Dr. Chi-Mbatoh. Permit me to just call you Pascal.
Yes.
Please stop sharing your screen.
Yes.
That was a very beautiful presentation. Obviously, you're a GP just like myself, and we see a lot of this all the time. We see people coming with their parents and concerns about memory. I mean, could you just tell the public about what it takes when people actually come and tell us that they're struggling, that their parents might be struggling with memories, memory issues? Just let them know that it's not difficult. We're always there to help them. Can you just tell them what we do when they come and how long the waiting list now to get to the memory clinic, and what can be done while they're waiting to be seen in the memory clinic? Because that can sometimes be the frustrating thing when they're waiting to be referred.
Yeah, the key thing there is that when you come to see us in primary care, although we're waiting for a diagnosis, we still treat the patient. And in treating the patient, we identify the problems that are there. So if that patient is very anxious, then we can give some medications that will manage their anxiety. If we notice that it is a caring issue, as in the patient is struggling to cope with basic things at home, we'll get the social services, and the social services would be able to assess that person at home. And then also, it's not only us, we have the community and the district nurses, the community matron. They actually do a lot of support. They offer a lot of support to this patient. So while you're waiting for your diagnosis, the diagnosis is a paper. The care is provided by the clinicians. So the nurses, it is a multidisciplinary thing, because these are the same people who need feeding, they need help with walking, they need help with their personal care. So quite a lot of things we can do while we are waiting for the diagnosis.
Yeah, I guess the one of the things we can't do is start the medication, right? Because we don't have the diagnosis. But you're absolutely right. All the other things can already be done, and that's why it's so important that if you have any concerns, where GPs are asked anything, right, Pascal? So anything, any concerns, bring it. We will not be upset. We won't say you're being silly. We will take everything seriously and rule out all these other things. Now, and there is a question in the chat which was supposed to have been in the Q&A, but it's quite a good question, and I think will fit in what you've just said now. And I know we get this all the time. So how do you manage a patient with symptoms who is refusing to see a doctor for the diagnosis?
Yeah, that is a very interesting question. And I would say here is this: most patients don't want to lose their independence. And if we go back to that first slide where we talked about the stages of the disease, it is a progressive condition and we know there is no cure. gradually, with support and understanding, when you explain it to the patient, you should also know that these patients have their rights. When you explain it to them, most times when the patient realizes that they can't cope anymore, they would accept. I struggle to find a situation where a patient would refuse to the end. So as a disease progresses, it's not a day thing, it's something that takes years. So at some point, the patient will still need that care. So we just need to go along with the patient, and things normally we provide the care until the patient really needs our help, and then we'll come in.
Exactly. And that's basically something we face a lot, isn't it? Family members coming to say, my mother, my dad, they're not the same, they're losing things, but obviously we have to assess, and mostly if it's early stages, we can't force them to do anything, especially if they're still looking after themselves, you know, and still going out doing the shopping. But obviously we know that they might be early stages. So yeah, not very easy. But yeah, Dr. Paschal, thank you so much for that presentation. There's still many questions for you. Carlos has some which he's going to put on the question and answer box, and we're going to come back to that at the end, because we need to get to our next speakers. And our next speaker is in Cameroon. Very exciting, because we'll tell you at the end how she's linked to CamDoc very well, and we'll tell you that at the end of our presentation. Her name is Mrs. Judith Ngang, and she's an agronomist from the École Nationale Supérieure Agronomique, Chang, Cameroon. She did a master's in rural development at The Hague, the Netherlands, where she got interested in alternative development approaches. She has 30 years of experience with the Ministry of Agriculture in Cameroon before her retirement. While in active service, she found time to do action research in grains, nuts, and seeds, from which she created her self-managed production company, putting on the local market her own brands in the sector. She puts value to Cameroonian nuts, in particularly helping showcase Africa's rich resources. She finds time to raise awareness on nutrition and health in every community in which she finds herself. For her work is always fun. She loves assisting communities in their development efforts. So this is all her background, but she's here to talk to you about how she does all of that and also cares for someone with some memory issues. Over to you, Mrs. Ngang.
Thank you, Dr. Bello. Thank you, Dr. Bello, for inviting me to this prestigious platform of CamDoc. So I'm going to talk about the challenges of caring for an elderly person in Cameroon. That is my outline. I'm going to talk about, give an introduction, the concept of human scale development, my mother within this context, my experience looking after her, and ask the question at the end, what next? So we say life expectancy in Cameroon is 60, and my mother clocked 90 this year. And when I look at her, I flash back at her early years when I was still young, and looking at her, I see so many factors that contributed to this level of longevity, this level of ease that she's experiencing today. And so instead of just citing these factors, I decided to conceptualize it, which I'm going to present in giving my presentation. In that light, I'm saying that I believe that health is first and foremost preventive, and that to have an amazing finish requires preparation, and that with an adequate preparation, the upper floors in life can be lived with reduced intervention of caregivers. So why this concept of human scale development? If I look at what Dr. Valley has just presented, the human scale development enables us to conceptualize, to capture of all what it means to be human. So human scale development was put in place by the economist Manfred Max Neef. And he says that development is about people, not about things. And I'll add here that development is first and foremost personal development. So he says that development is geared towards meeting our needs, our human needs. And he says that there are 9 human needs which do not vary from culture to culture or over historical periods. He says that we have a distinction between the needs and the satisfiers of these needs. We should make that distinction because the satisfiers will vary from culture to culture, and even from one individual, it will vary over some time. You change the satisfier. A satisfier is how you satisfy these needs. The various satisfiers, there are many, many satisfiers. He says that we should look at these needs as a system. So there is no hierarchy. On the contrary, these needs are interrelated and they interact with one another to produce an effect in the community. So the needs will have complementarities, they'll have simultaneities, and they'll have trade-offs depending on how these needs are used. Then he says that when needs are not adequately met, it will generate poverty, and which will generate a pathology. So he says that instead of looking at poverty as a level of threshold or income threshold, we should now see poverty as many poverties. So there's poverty of affection, there's poverty of protection, there's poverty of affection, depending on whether these needs are met or they are not met. So looking at my mother in the context of human scale development, at 90, my mother looks happy, feels fulfilled, and full of life. And what aspects do we see from the human scale development theory that enables her to enjoy this? Firstly, I would say that as concerns the subsistence needs, she had good physical and mental health, she had a shelter, she had enough food, she has 8 children, all of whom are alive and independent. She had her own residential space. As concerns affection, my mother is actually a generosity icon, and she prioritized family. She took good care of loved ones and knows how to share with others, enjoys family, enjoys relationships. Then as concerns understanding, she has a strong critical conscience. She's full of intuition and rationality. She is a member of many groups and well integrated in her community. As concerns participation, she's very hardworking. She's dedicated, consistent, loves solidarity. My mother loves leisure. She has a high sense of humor and great peace of mind. She's very passionate and determined, full of imagination. And that's what I'm talking about, creativity. And when it comes to identity, she has a strong sense of belonging. As concerns the values and that at 90, she traveled to interesting that she could do that on that sense freedom. She's a very autonomous person, very open-minded. But it looks beautiful, but that's not, there are buts as concerns my mother. My mother was so independent. When I went to Bamenda, she would give me food, cook food. She would climb the stairs in her home and be able to give me food, prepare her own food, go to all her meetings, even when she was close to 90. But due to the crisis in Bamenda, what happened? She moved house and became very sedentary with consequences which are really outstanding. And one of the consequences which I see is frailty. She has become so frail. And that makes me understand the importance of activity as we live. Activity is very, very important. We have to keep working, keep doing something, even if it doesn't pay. So my mother has new and worsening of pre-existing conditions like hypertension, diabetes, and some conditions that she may normalize until, as for instance, constipation, and learning how to be proactive about the dietary changes or medicines if required. Polypharmacy, so many drugs to be administered every day. In fact, I have to learn all of that. And good enough, she would tell me that this is the drug she has to take this hour. this is a drug she has to take this moment. As concerns her eye medication, she will say that we'll put this one time a day, we'll put this one 3 times a day. She really helps in that. So as Dr. Ngwa said, it's really a partnership because she's really helping us. We have challenges taking her for multiple appointments, lack of coordinated care for her with multiple ailments. Now she's in Bamenda. My junior sister with whom she's living has to go look at all the medications that she has to take, you know, liaise with her to see how to give those medicines. Then we have, of course, moving from town to town means that each doctor treats their own organ, and then there is a lack of holistic care of the patient. So moving to another town long term, lack of previous records for the new doctor to be up to date. My mother has become so very dependent as concerns feeding, because we have to figure out what to cook for her. The time that she's been with me for several months today, we have to figure out, even if we are not very intentional about what we eat, we must be intentional about what she eats, because becoming sedentary affects her gut. So we have to make sure that we give her foods that will enable her to have her digestive system will be fluid. As I said, my mom is very bright. She speaks a lot of wisdom and is proactive, but occasionally she goes off topic and is confused. And I used to ask myself, but what is happening with my mother? Because I know who she is. I know that she's bright, she has a lot of wisdom. So it's discussing with Dr. Judith, and that she enabled me know that the memory she can get lost, she can get memory losses. And I started opening up myself. And with this webinar, I'm understanding that I have to really tone myself to what is happening with her aging brain. I'm so grateful for this webinar because it has really changed my perspective with respect to the care that I give her, because sometimes I used to shout at her, but now I'm going to tone that down. So the consequence of being sedentary and inactive is really, really serious. And then I start asking the questions. At what point does she really need extra help? At what point should we give her sanitary towels? Actually, we think that if we intervene a lot in her life, it may help her to plummet further. And then we need to know the balance, but I don't have that level of awareness or training that enables me to know when to do what. So I'm asking myself, should we get a full-time caregiver for her, or should I continue to manage with my part-time services? And if she's completely taken care of, will symptoms not worsen? One important aspect in this relationship is the state of the mind of the caregiver. Dr. Ngwa has raised a point which is talking about care partnership, and I agree with that, because we need to know, is it an obligation for me, or is it out of love that I'm doing all of what I'm doing with respect to my mother? You know, it has gotten to a point where I have to sit down, make it intentional, that it is a giving affection and receiving affection is something that I have to do with joy and have a lot of fun in it. So I've gone through a process whereby I really have pleasure giving that care to my mother. So the question now is, what next? Let me go back to the other slide by saying that there's a lot of support from the family, but the question is, what next? Holistic care for elderly patients in Cameroon is really a necessity. So we say that preventing and improving dementia by keeping an active mind and body is so, so vital. And that carers being proactive and empathetic, they should be proactive and empathetic, but they need to be trained to do this. And then we need to have more of public education on all of this, because I believe that so many people do not have this awareness. With this, Dr. Bello, I'll come to the end of this presentation, and I'll say in Mancon, Mia.
Mia, thank you so much, Mrs. Ngang, for that lovely all-round presentation. I can see Dr. Ngwa smiling. Dr. Ngwa, are you going to answer her properly? Because I don't know any Mancon.
Oh, it's a Mia.
You say what?
Mia.
Mia as well.
Thank you, how about?
Okay, perfect. I did say that. Wonderful, Mrs. Gang. That was so good, as I said. And you raised many questions on there about when we're looking after our mothers or any family members in this sort of situation. Obviously, there's the duty to do it, but also, we have to try and do it even when it's difficult with all this empathy. And we also sometimes, we're also human, aren't we? And I think Dr. Ebode is going to maybe talk a bit about if there's any kind of support for carers. Like, do you have any support in Cameroon, any support for you, any support groups that you can, when you're feeling a bit tired, or you can talk about your experiences? Is there anything like that exists in Cameroon, Mrs. Gang?
To my knowledge, I don't know of any group, any support group that does that.
Yeah.
No.
Okay.
Caregiving or care partnership as concerns the elderly in Cameroon is now a home-based thing, family-based thing.
Yeah. Well, Mom is lucky she has 8 of you, right? You said.
Yes.
Excellent. She's very lucky.
It goes round and round.
Excellent. We'll come back to you, Mrs. Gang, because as I said, Dr. Ebode is going to probably touch on some of your questions, what next, and for others that are in Cameroon thinking of, how they can deal with this, I think the next presentation will be very helpful. And just as for everyone to know, Mrs. Gang is actually mummy to our previous secretary, Dr. Judith Ngang, who is a long-standing and one of the best members CamDoc has ever had, and I say that and I say that with no bias at all. Okay, so moving on, our next speaker is Dr. Ebode-Ntsama. She's a consultant in internal medicine and geriatrics at Yaoundé Central Hospital. She's also a senior lecturer at the Faculty of Medicine and Biomedical Sciences of the University of Yaoundé 1. Thank you, Dr. Ebode-Ntsama. Over to you.
Thank you, Dr. Bello. Thank you, all of you, for having me for this very interesting webinar. Now we'll discuss please let me share my slides. I don't know if I've already shared it.
Not yet. Share it now.
Not yet, sorry. Okay. Is it okay? Do you see my slides?
Yes, we can see. Yes, we can see your slides. Thank you.
Okay, very good. So I was saying that now we will discuss the diagnosis and management of dementia in Cameroon. I have no conflict of interest, and this is my outline. So first of all, I will present the key facts on dementia in Cameroon, and then I will present how we manage to diagnose and take care of our patients with dementia in Cameroon, with all the challenges that we are facing. The proportion of older people is increasing worldwide, and that global aging is also described in Cameroon, notably with the increasing life expectancy.
Sorry,
and
sorry to interrupt you. Just
yes.
this noise in the background. Yeah, it's gone off now. Thank you.
It's okay.
Background.
There was a sound in the background. Okay, sorry.
Yes, from the TV.
Okay, maybe okay, give me a few minutes.
Yeah. Yes. Thank you.
Sorry. Okay. Is it okay now?
Yes, it's okay. Thank you so much.
Okay, so I was saying that according to the last census from 2018, about 5% of Cameroonians were considered as older people, but we have a lot of concern on their health status. That's why we are trying to increase awareness on other people health issues, including cognitive disorder. It is true that aging is associated with several age-related changes, but it is important to keep in mind that dementia is not part of normal aging, because usually people will seek medical advice very late in our setting, because usually they think that cognitive impairment is a manifestation of normal aging. In Cameroon, about 1 of 3 older persons probably live with cognitive impairment, ranging from mild cognitive impairment to dementia. But the prevalence of dementia varies widely from 2 to 11%, depending on the population, but also on the method of assessment. And Alzheimer's disease remains the leading cause of dementia, although it is underdiagnosed, but we have other causes, including vascular dementia and even HIV associated neurocognitive disorders. But we have also other relevant factors that may impact the cognitive status of our patients in Cameroon. We can have multimorbidity, people with hypertension, diabetes, hypercholesterolemia, and other chronic conditions that can also impair their health status. And we note also the increasing prevalence of other conditions known as geriatric syndromes. We can have dependency, urinary incontinence, falls, etc., etc. But now, coming to the diagnosis of dementia, usually the diagnosis is made by a physician, neurologist, psychiatrist. It is true that geriatricians are still, scarce, but only 2 of us are working actually in Cameroon, and we are both working in Yaoundé. So we assume that in other parts of the country, you cannot see a geriatrician, but at least sometimes you can see, although they are also not in a great number, you can see a neurologist or a psychiatrist. But due to that scarcity of specialists, the Ministry of Public Health has trained advanced practice nurses in mental health. So they are trained to screen, diagnose, and then refer a patient with suspected dementia to the specialist for further investigations. Generally, after the complete physical exam, clinical evaluation with laboratory tests and other tests, one of the key points is also imaging of the brain. Usually, we have the computed tomography and the magnetic resonance that are available, but they remain very, very expensive in our context. Most patients can sometimes afford for the computed tomography, but we know that the MRI is, mostly recommended, but many patients cannot afford for the MRI. Apart from that, the cognitive tests are also an important part of the assessment. Usually, it's the physician, it can be the neurologist, even the general practitioner, if he's well-trained, can perform at least the mini-mental state evaluation to screen for any cognitive impairment. Thereafter, he can request the advice of a neuropsychologist for more in-depth assessment, because usually when we have the assessment of the neuropsychologist, we can have a broad map of the cognitive impairment, and this can also guide the management thereafter. But assessing a patient with dementia is also looking at how he deals with activities of daily living. to know the level of dependency, know how dementia impacts his capacity to live in his social environment. For example, we assess how the patient dresses himself, if he's still able to take a bath, if he's still continent. But we also look for other more complex activities like managing finances, medications, etc., etc. But in our own experience, we have noticed that some of these tools are not really adapted to for example, to our rural setting. Many people are not able to use a phone in our rural setting, not because they are demented or because they have a cognitive impairment, but because this is not part of their, instrumental activities. Some of them will do farm activities, hunting, etc., etc. So we should maybe think on how we can assess those activities that are proper to our own community. Now, come to the management. We have two approaches, the non-pharmacological approach and the pharmacological approach. But it is important to say that in Cameroon, the majority of all the people who live with dementia usually stay in the household, meaning that family caregivers have a major role on managing those people. That's why the key step when diagnosing a person with dementia is the therapeutic education. Therapeutic education to explain to the patient, if he's still able to understand, or to his caregiver, what is dementia and how the disease will progress, how to deal with that progressive loss of functioning, and how to deal with all the behavioral changes that may occur during the course of the disease. And in that particular approach, it is important to say that many other health, professionals, because they are not only health professionals that are involved in the management. So we involve even the psychosocial, the social workers, for example, to look for the social support of the patient. Other interventions are also interesting in our setting. We have cognitive stimulation, even though many centers have few trained personnel to that particular part of the management. As we said earlier, drugs, the effects of drugs are very limited on the course of dementia. It is true that many drugs that have been, that have shown some slight effects on the evolution of the disease are available in our setting, like what we call acetylcholinesterase inhibitors. But it is true that with the patient coming late to the hospital, sometimes you hesitate to start those medications, knowing the cost and finally the benefits that you can have on their cognitive function. But there are many other symptoms that are important to control because, for example, a patient with dementia can exhibit symptoms of depression, a lot of anxiety, other behavioral changes like agitation, etc., etc. And it is important to control those symptoms because it has been proven that it can worsen the clinical status of the patient. Sometimes some behavioral symptoms can even be life-threatening for the patients and his caregiver. So it is very important to manage those symptoms. Usually, we can use non-pharmacological approach, but sometimes we can also prescribe some psychotropic drug to improve the quality of life of the patient. When doing the therapeutic education, usually we also discuss how the dementia will continue to progress and finally reach the end stage of dementia? How can we discuss finally with the family caregivers the relevance of life-sustaining interventions in that particular case? And it is important to emphasize on the quality of life of the patient. It is true that we do not have national guidelines in that particular case, but how we can help families is usually by requesting admission of those patients who are presenting with very late and severe dementia with short life expectancy. We admit them, and usually the death can occur in hospital or sometimes at home. We are facing a lot of challenges to diagnose and manage dementia in Cameroon, but the major challenge, I think, is the beliefs, because you will see people thinking that maybe it's witchcraft, and they will not even seek medical advice when they will see some behavioral changes in an older person. They will try to maybe stigmatize the person, or you can also have some abuse on older person just because people are not aware of what is dementia. So there's a lot of work on educating and our population on that particular issue. But even the health personnel is not really aware also. So for the early recognition, there's also a lot of work to do to train our personnel to diagnose and at least screen patients who are at risk of dementia. Concerning the support system at the institutional level, there is a major issue concerning the cost of the management of dementia. All the expenses are out of the pocket of the family caregivers. It is very, very difficult for them, for example, to pay for all the paraclinical investigation. And you know that once they know that maybe dementia is not curable, sometimes they will abandon, because they will see, is it really necessary to spend a lot of money for something that maybe cannot be cured? So it is very difficult, and we maybe hope that with the universal health coverage, maybe at least it can alleviate the burden, the financial burden for families. And concerning social support, the question on nursing home is also crucial. It is true that in our setting, we do not have nursing homes like in Western countries, but I think that it's a question that something that we need to think about. What can be the place of nursing homes in our setting? Does it fit with our cultural behaviors? Another point is that it is true that it is very, very difficult for us to manage patients with dementia. And I think that one of the points is also because we are not really, some of our healthcare professionals are not trained to diagnose or to make screening campaigns. But there are several initiatives that are ongoing to address that particular issue. For example, we have Professor Alfred Jamshi and his team who are presently working on a project, the Brain Research Africa Initiative, on to understand the cause of dementia in our setting, to look for local solution, because it is true that we have, the Western model of care, but is it possible, in taking into account our own resources, to diagnose or to screen our patients and propose interventions that can also be beneficial for the patient, first of all, but also for the family caregivers, knowing that they are the main financial support for the patient. this is not my last slide, but I think that it is important to maybe make a small summary by saying that the diagnosis of dementia requires a high index of suspicion, especially in a context where there is a scarcity of neuropsychiatrics specialists. And I think that it is true that multidisciplinarity is the rule, but we need to work with the family caregivers. I think that they are the main pillar of the management and for even the diagnosis, because they are the one who usually request for the consultation because they notice a change in the patient or in the relative, and then they will seek medical advice. So I think that it is very important to work with the community and with the families. We are still facing those challenges like social beliefs, late presentation, and weakness of our support system. But I think that stakeholders must continue to work to increase awareness. And this is, for example, one of our activities in the geriatric service, where we use to screen patients not only for cognitive disorders, but also for all age-related conditions that may impair their health. Okay, so this is my last slide, and I would like to thank all the CamDocUK for giving me this opportunity to discuss on our own experience of managing patients with dementia in Cameroon. Thank you very much.
Thank you so much, Dr. Ebode-Ntsama. It was really, I mean, some of the numbers you were bringing up there, you know, there's only 2 of you in the whole of Cameroon. There's only 5 neuropsychologists. I don't know how many neurologists there are. It's just mind-blowing. I mean, what message can you give to the Cameroonians, you know, about, you know, how, you know, you see carers like Judith's mom there, you know, what can they do? You know, what are the main things to do? And especially the medication, you said it is so expensive. Tell us how much that costs as well, you know. How can people really deal with this?
Okay, if I'm taking the main molecule used, for example, for Alzheimer disease, donepezil, the generic form is around 8,000 francs. But when you prescribe the one, I will not cite the lab, it can reach the brand name, yes, but I think it's around 18,000 francs.
Wow.
And it's for 1 month, And usually those patients would not have only donepezil, they will have other medications to control mood, to control agitation, anxiety. Usually they are polymedicated. So, and it is not only a matter of buying drugs, they must eat. You have to look for their comfort. Some of them have urinary incontinence or fecal incontinence, so you have to buy diapers. So all those expenses are not, and of course, you must continue the follow-up in the hospital, go for the appointment with the doctor. Sometimes the doctor will request workups, etc., etc. So it is very, very difficult for the family caregivers.
We have some questions for you in the question and answer box. There's a lot. The first question was, do you have a memory clinic? And how does the state assist families living with patients with dementia? How are these patients safeguarded? Do families receive any support from the government? That's like 4 questions. Sorry about that.
Oh.
I can repeat them.
Okay, we do not have a memory clinic properly, but we work a lot with neurologists.
Okay.
We work in concert with neurologists. Usually sometimes they are the one diagnosing the patient, and then they will refer the patient to us for a geriatric assessment. But we also refer patients to neurologists for further investigation sometimes, because it is true that the leading cause is Alzheimer's disease, but you know that there are so many other causes of dementia that it is very difficult sometimes to make the difference between those different type of dementia. So it is important to work in a multidisciplinary approach. That's why, but I think that maybe we need to have our own, I think, our own models, knowing that we do not have enough healthcare. This is the practice in Yaoundé, for example. But what about those who are in villages far from the capital? So we need to think of how we can I mean, propose also care for those who are not able to see a neurologist or a geriatrician or any other specialist. But I think that but I think that the role of the advanced practice nurses in mental health is also crucial. But we have to pay attention to the fact that sometimes they will start treating patients without referring patient for further investigation. And this is the main problem that we have now, because we see a patient coming with a lot of psychotropic drugs. I mean, this is maybe the main issue that we have with that. I think fantastic idea at the beginning, but now we have to make sure that they are not getting out of their main role.
Yeah. I mean, we had a question way before you had started to present, which is basically saying that in Cameroon, dementia patients are reviewed by the neurologist with a lot of focus on medication and interventions, as you've just said. There's a lot of help available in the UK, but do you know any sort of help or networks available in Cameroon that is sort of non-pharmacological?
Okay.
Is there anything like that you're aware of?
When you're talking about help, is it institutional help or informal help?
Well, I guess question is obviously we're given medication all the time. Is, you know, are there other things that can be given? Obviously, Dr. Paschal mentioned that we have nurses and support staff, carers, other things, you know, we have people that come into the homes, diapers and things, give diapers and things. What kind of other help can be available apart from the family? Is there anything?
It is true that we have now some people who are providing home care, but it is not well formalized. So we need to make sure that people who are going to give cares at home are trained. But this is the major problem, is that people are going providing care that are not well controlled. Sometimes they will call you when maybe the patient is not even able to speak again, and then they will ask for you to I would say to do a miracle. But I mean, it is very difficult, and usually some of these people are taking money to the family, promising for a relief of the patient. But you know, I think that our government must also focus on aging issue, because when you look at other conditions that are we have a procedure, we know how to train personnel. But when you look at the cognitive disorders, I think that it is not well. There's a lot of advocacy, of course, but actually there is no formal support at the level of the institution, the public health, or the Ministry of Social Affairs. No formal. But I think that maybe it is pending. We are still waiting, and now we have to help families as we can by sometimes providing home care. But still, since it is not well formalized, it is also very difficult to propose a type of specific care. For example, when you have palliative care at home, if the patient died at home, it will induce another procedure that you cannot really justify if there is a problem, you see. So people are obliged to come back to the hospital, maybe to formalize all those cares.
Yeah. Yeah. Thank you so much, Dr. Ebode. Last question for you, but I will probably come back to you if we have a bit of time.
Okay.
Do we have tools for dementia screening adapted for lower literacy settings, like so in some parts of Africa, other than the MMSC or MOCA?
It is true that there is a team in Senegal who has worked on a test. The name is Test du Sénégal. But I don't know if there is another test that has been approved or validated, but the test is used in Senegal. In my experience, I use the MMSC or the mini-cog, but I don't think that we have, but I'm sure that researchers are working on it. As I was talking about, for example, tools to assess daily living activities, we need to adapt those tools to our own setting.
Lovely. Thank you so much, Dr. Ebode. And that will take us right back to Dr. Ngwa. There was a question there for him from the beginning, which was, please kindly explain what you mean by you can have Alzheimer's disease without dementia and vice versa. That's the question from Constance. It's been there for a bit.
All right. Now, Alzheimer's disease is the condition whereby you have abnormal deposition of these plaques in your brain. And these plaques are normal proteins that are deposited in the brain. When you have the disease, as I said before, you don't have all those 4 tools of the dementia syndrome. So you could start having those disease in your brain, which can be diagnosed by a few ways. One, you can do a scan to diagnose those plaques in the brain. 2, you could do a lumbar puncture and take the fluid and send to the lab and diagnose those plaques as well. But when you go through all the neuropsychiatric testing, you're not scoring on the dementia range. Remember, as I said, you could have Alzheimer's disease for 10 to 20 years before you start developing dementia. Now, you could also have dementia that's not due to Alzheimer's. As I said again, there are about 70 to 100 causes of dementia. So you could have a vascular dementia, you could have Lewy body dementia, you could have Pick's disease. There are quite a lot of them, which is not Alzheimer's. So dementia doesn't equate to Alzheimer's. Yeah, up to 50 to 70% is Alzheimer's, but there's a lot of other things as well. So you could have the disease and not be the dementia range. And you could have the dementia, which is not caused by the disease, but caused by some other disease as well.
Yep. Thank you very much. So, and there's another question there that was been there for a bit. Does that mean that alcohol and HIV are high risk factors in Cameroon? I mean, I guess there's a lot of consumption of alcohol in Cameroon. I don't know specifically about HIV, but I guess they're asking if it means we'll have higher amounts of dementia in Cameroon because of alcohol and HIV. I don't know if anyone wants to comment on that.
Yes, those 2 things have effects on the brain, but don't forget, people who have those 2 things have other high-risk behaviors anyway. They might die from something else before they have the chance for the dementia to develop. But that said, anybody below 65 in the West who has a dementing process need to have an HIV test done, syphilis test done as well, because they've been known to cause. And alcohol, definitely, yes, it's significant. If the alcohol doesn't kill you from cardiac problems and other stuff, it's just a matter of time you're going to develop alcohol dementia. And I think we tend to see that a lot more in the West in younger people than I saw them in Cameroon for some reason. I think we tend to see more. I guess it's because sometimes we think that we drink a lot in Cameroon, but if you come to like UK and Germany, I think that the alcohol here is a different spectrum, really. So you see more younger people with dementia caused by alcohol than I saw when I was in Cameroon. But it certainly is a problem in Cameroon anyway.
Excellent. Okay. And there's another one there for you, which is it better to treat a patient with advanced dementia in their home or hospital?
Yeah, that is it is highly individualized. But I would say this: the hospital is a very bad place for people with advanced dementia. Particularly the emergency department is a dangerous place for them because it actually unsettles them. There's a lot of hyperstimulation. There's a lot of the risk of them developing a delirium on top of a dementia is higher when they go to a hospital. So when somebody is getting to the advanced stage of dementia, as you know, in the UK, what we would tend to do is have a discussion, have an advanced care planning. What will you want if you become so unwell? And sometimes you could have adequate care at home, and the disease the patient has got is not quite serious. You don't have to bring them in a hospital environment where you unsettle them. We get a discussion all the time with some of the relatives who want their patients to be in hospital. And I explain to them this: one, an acute hospital, so they're in an acute ward. What happened? The light is there all the time. They're hyper-stimulating them. The tourists are coming and going, it's hyper-stimulating them. They're in an unfamiliar environment, they're coming and going. They're seeing different people, many of them. So being in a hospital environment increases your risk of actually dying if you have dementia. So if you could get there, that disease is not serious. I think that the best place would be in their own familiar environment. If it is challenging, you know, in the UK now, we now got care homes for people with severe dementia that's challenging, called the elderly and the medically informed EMI homes, where those staff can actually manage their behavior there. So those discussions I have quite earlier. And that thing that Dr. Chi-Mbatoh put at the end, that this is me, is very, very important, because it would try to say all of those things as well. But yeah, an acute hospital is a bad place for dementia patients.
Thank you, Dr. Ngwa. I think Dr. Paschal and Dr. Ebode want to talk about it as well. Dr. Paschal, over to you, and then we'll go to Dr. Ebode-Ntsama. Please unmute yourself, Dr. Paschal.
Yes, Dr. Ngwa, you are absolutely correct in terms of the answer to that question. And that's where, when these patients can't stay in hospital, we in the community take care of them. And most of the times that form, that "this is me" form, usually when we go to do the care plans, we'll write those plans there, so that even when the patient comes down to the hospital or other medical personnel to see the patient, they will know that there is a care plan for this patient, and this patient can only go to the hospital if they cannot, under any circumstances, manage a patient at home. Because as we said before, in terms of the symptoms, increased anxiety and everything is quite distressing for the patient. And for the best interest of the patient, usually we prefer treating the patient at home.
Thank you, Dr. Paschal. Dr. Ebode?
I totally agree with what Dr. Ngwa and Dr. Paschal said earlier, but it is true that our own experiences in Cameroon is a bit different, as even during the announce of the phase, where you're trying to explain how the disease will progress, people usually do not understand how a patient with what they consider as a life-threatening illness with a severe disease are not, I will not say authorized, but we do not recommend them to come, for example, to the emergency unit. They will not it is difficult for them to understand that. So I think that it is maybe due to our maybe cultural behavior, that when somebody is sick, we have to go to the hospital. So we are still dealing with that, especially for the advanced care planning, as people are not prepared to end of life. This is another part of the challenges also. I don't know if I've mentioned it, but it is very, very difficult sometimes to convince the family that sometimes home care are more beneficial for the patient, and even for themselves, for the family care, because the hospital is so stressful, even for the caregivers.
Okay. Thank you so much. Mrs. Ngang, what advice would you give to someone just starting their caregiving journey, especially with all of the issues that we face in Cameroon? What piece of advice could you give them?
The very first thing I would say is that you have to rethink it, because it's not something that you really thought of it. It just fell on you. So you have to sit down and go through it and be prepared to do it. And do it relaxed. Do it joyfully. Do it so that you gain some pleasure in it, so that you will not be stressed, because it is really demanding. It is really, really demanding. It's costly. And that's why in presenting my Max News human scale development, my interest is to let those of us who are still aspiring to reach that age, reach that point where we will not need caregivers.
Yeah.
It's demanding. It's really demanding. So you need to think about it and do it relaxed with fun. Enjoy it. I don't think it matters what you have, but that relationship that you build with the person is very, very vital in making the patient happy.
Amen. Excellent. Thank you so much for that. And I guess, Dr. Ngwa, you have got your hand up, and you might also elaborate on this. I mean, and maybe Dr. Ebode, before we wrap up. I mean,
sorry.
Yeah, and I'd like you to answer this after you make your comment. A lot of people will say, well, you know, money is expensive. There's not enough specialists. Why do we even need a diagnosis of dementia? And you know, why do I even need to go and see Dr. Ebode-Ntsama? Why?
So is that for me?
Yeah, that's for you.
Okay.
Yes.
Yeah.
And then
Well,
I'll
okay.
go to her.
Before I come to that, I just want to emphasize what Ms. Ngang said. And I think she's put it quite clear, I won't put it better than that, very, very clearly. And I'm quite happy that she's been saying about keeping going before we get to that stage. And there's one point in which I want to emphasize that she made. He said, keep doing something, even if it doesn't pay. Absolutely important. And in the West, it's been shown that volunteering for nothing actually increases your life expectancy. So I think that's something we need to do. There's not a retirement anymore, isn't it? You just change from one job to the next. And so that's very important. Now, in Cameroon, it is a user pay. It is the user fee. People pay for their medical treatment. So people will have to decide what is important to them. And if you say to them, again, I've got no experience in managing dementia in Cameroon, but I've got experience in managing HIV. If you say to them, well, this could just prolong about 1 to 2 years, they're going to look at the cost benefit and think to themselves, is that worth all the money, considering that I have to do? Why sometimes the UK we're quite spoiled, because these are all paid for. So of course, you give it, the family don't pick any bill. So I can imagine some families that are stressed. I mean, yeah, Mrs. Ngang's family can manage and deal with those. There are some families who are living on less than $2 a day who would not be able to manage those kind of burden of dealing with older patients. They have to make healthcare priorities. And I'm sure if you want to make healthcare priorities, your priority will not be somebody above 70, will be somebody below 5, some in the teenage years, you know, the ones who are still coming up. So I can imagine that sometimes those decisions that are coming from families who are paying the bills has to be biased towards supporting the younger ones than supporting the ones who's already spent a significant part of their life.
Thank you. And a question for Dr. Ebode-Ntsama. Lovely presentation. So if I'm a carer in Cameroon and needed to learn how to care for my mother with dementia, who do I talk to?
I think that maybe we'll share my slide on the brain initiative, because they are currently doing also training for caregivers of people living with dementia. I think that it's important to share that slide, maybe the phone number. We'll try to share it with the community also.
Perfect. All right then. Well, thank you all so much. We ran out of time ages ago, but as it was such an important topic that we had to obviously continue. You guys all had something very important to say. I just urge you panelists to just have a look in the question and answer box and just answer some of the questions that I haven't been able to ask you all. But I'd like to thank you all for your insightful presentations, and to all our panelists, all our attendees that have joined us today, and those that are still here at 8:05 when we were supposed to finish at 7:30. We've explored key aspects of dementia, from understanding its early signs to addressing the challenges of caregiving and the strategies for diagnosis and Management in Cameroon. Your contributions today remind us of the importance of community awareness and collaborative efforts in improving dementia care. So let's take these discussions beyond today, whether it's recognizing the early signs, supporting a caregiver, or advocating for better resources and systems. Together, we can make a meaningful difference in the lives of those impacted by dementia. So we really hope that you found this session informative and engaging. Please stay connected with CamDocUK for future webinars in our Talking with the Community series. This webinar was recorded and will be available in our YouTube page as usual. Please share these to your contacts who were not able to attend today. And further information about our activities can be found on our website, camdocuk.org. And our gala, I'm going to already put that in, is going to be next year on the 5th of July, 2025, 5th of July, 2025, save this date. But before we log off, a special thanks to those behind the scenes. So please, cameras on, and we shall start with the one and only Dr. Anambene. Please say something. Hello, sorry to keep us late.
Hi, everyone. Thank you for attending.
Dr. Gael Nana, our educational lead, please say something.
Thank you very much to all the speakers for giving up your time, and to the members of the public. We are happy to hear from you about suggestions for future webinars. Thank you.
Dr. Montio Morgan.
Hello, everybody. Thank you so much for coming. It's been wonderful, and we hope to see you again soon.
Thank you. Dr. Gisela Didino.
Hey everyone, it's really been a fantastic evening, lots of learning and sharing. Thank you all for your active engagement and participation, and see you next time.
Thank you. And last but not least, I hope she'll be able to turn on her camera, Dr. Vicky Kamwa.
Yes, thank you very much. Just like my predecessor just said, it was really good having you, and then we'll see you on our next session. Please do not forget to fill in our forms. I think we've shared it in the chat. Thank you very much again, and thanks to our beautiful panelists.
Excellent. So thank you all once again, and have a wonderful evening. Good night.